Okay, so good evening. It is 7:05. My name is Kia Baird, and I am joining you in my first kind of official role as the HIC coordinator. So welcome to our evening series. Um, let's talk about HIC really, really very quickly. Let's see if I can find what I have. So you all are nodding because you can see my screen. Is that happening? Yes? Okay, I love it. Okay. So the HIC is the Health Improvement Collaborative, and it's a collaborative in Southeastern Connecticut, a group of organizations, and they're committed to the work of creating opportunities for the health of all the folks who live here, right? So all the things, all these organizations, community members, leaders, and heads of communities getting together to do the work to make sure that the folks that live in our region are living their healthiest of lives. And that shows up in several ways. But let's see. Ooh, it worked. Okay, so so to set a kind of a framework, an intention for this series, this racial equity series, uh, the framework that we use is around the social determinants of health, which I know is language that many of you all have heard, probably even more than I have. But as you see down kind of this stack of what social determinants, right? These are the things that affect our health outcomes, our education, where we live, our transportation, our employment, those things. So this is the framework with which the HIC and many of the organizations that are in the HIC or represented by the HIC that we use when we are determining our work. And in the last year, I would say, we have determined that racism is the thing that kind of drives all of these social determinants. It's this through line. It's this connection, and that if we can address racism and all of the systems that it has impacted, affected over the generations, then we can help to do this work to increase folks' overall health. And to that end, some action teams have come out of this work of the HIC, and the action teams have decided to start doing this work to address this racism and have better outcomes for folks' health. And that's the framework for which we've had this evening series that you're here to share with us today. Okay. I'm looking at like the people that have been doing this for the last 3 years to see if I actually know what I'm talking about. I am excited to be doing this work, and what you see here is really some data that has come out of the research and the surveys and the work that the HIC has been doing. It is I know it's many of our lived experience to have experienced racism either in the healthcare system or in employment, but it may not, sometimes it feels like it's just you or it's just us, but this is real data. This is stuff that is happening that is quantifiable. And so here are just some of those data points. And again, as just kind of a setting the table for the conversation that we'll have tonight. Does that work for everyone? I can only see 6 people, but the 6 people I can see look very friendly and happy. So I'm going to stop. This just says thank you to our guests. I'm going to stop my share. And I am going to say thank you to both our guests, but I have the opportunity now to introduce to you New London's poet laureate, Joshua Brown, who is going to share some words with us. And in addition to a piece that I think was written for just this occasion, which is also very, very cool. So welcome, Josh, and thank you so much.
Thank you. You did an excellent job. It's always a wonderful, wonderful moment we can all get together. Can you guys hear me? Make sure I didn't mute myself or anything. Yeah, so I hope everyone's doing well. Feel free to cut your cameras on or off. I know we're used to this Zoom thing by now, but it is always great when we can come together to talk about this. I have friends and family who, yes, are affected by common things that wanted to come in and join the conversation. Mainly I hope that this is just able to help promote us to talk more openly and honestly about the things that ail us in our community. I did put together some things that I wanted to share, but I found myself more so just sharing stories that are common stories I know. Like I got off my phone with my cousin not too long ago. He's like, "Oh, I'm joining tonight." I was like, "Good," because I'm actually talking about you. But with that, I'm definitely thankful that we have Dr. Canty joining us. So I'm excited that we are addressing these issues. We are taking a serious stance on racism playing into these issues. I'm gonna go ahead and share what I put together. So when I first started writing, I always thought, what else can be said about the medical system that already hasn't been said? I could talk about the long distrust the Black community has experienced, about the history of experiments that have left us terrified of not having ownership of our own bodies, that we wait years just for a checkup, that currently has many of our Black and brown population unvaccinated, to the point where white communities travel to Black communities for free vaccinations, knowing that there will be more than enough to spare. To be honest, talking about this all can feel exhausting, but remember, this is all by design. Even preparing for tonight, I started thinking about my mother's blood pressure, my father and sister's diuretism, my brother-in-law's past surgeries, and a handful of stories popped in my head, and it can be overwhelming. But with that, a close friend of mine moved back home to support his mother, who was actually set to have a brain surgery. Now, not only did she have that one, she also had 3 following surgeries after a certain stent was infected. Unbeknownst to him, the night that he was driving back home, he was hit by another car. He ended up breaking his right arm in 2 places and totaling the car. Now, the other driver had no insurance, so there's little for him to do himself, as he was also uninsured. The lawyers stopped calling back. They heard he barred through the pain and even put off his physical therapy in order to work and help his family. By the time he did seek treatment, he had the idea to seek mental therapy as well. Unfortunately, he was told that he would be able to get therapy, but he would have to choose between the physical or the mental therapy. I guess his working hand, not his mind, is a terrible thing to waste. My cousin is an Army veteran who discovered that not only did he have dependency on certain medicines and he used to cope for his stress and anxiety, but he also found the weaponry and equipment that he shouldered all those years had left his back and knees in shambles. Shame, he was recently told that his back could possibly get better and the VA would be reworking his benefits. Imagine being one of the world's top athletes, award-winning at 16 and finding yourself in a hospital where your doctor refuses to listen to your concerns of pain and discomfort. You're a champion, surely you can muscle through it. Well, this was the experience of Venus Williams when she was to hear her cries and nearly lost her life. And sadly, though many think racial bias is a thing of the past, based on a National Academy of Science survey, 100 out of 200 white medical students still perceive that Black and brown individuals felt less pain when compared to white individuals. Not only that, but these same individuals were more likely to suggest inappropriate medical treatment for Black patients. These are the instances that Dr. Canty will be discussing, as Black women are 3 to 4 times more likely to die from a pregnancy-related complication and 2 times as likely to experience severe maternity morbidity when compared to a white woman. I'm hopeful, as with the rise of young Black and brown individuals joining the medical field, our representation can change a nightmare doctor's appointment into a moment of brevity, being able to share those moments with your doctor and see them as someone that can truly help support you and your needs. Side note to this, I remember asking for certain things to be done, and I was told that if they refuse to do those tests, to make sure that they mark it down in the exam and visit as well, so it can be documented that they are refusing to do a test for you. Fun little tip from my medical friends. Imagine you were set to go under the knife. You were forced to cut your hair for a procedure. Now, as Black people, our hair is our culture. It's our connection to our heritage. So what excitement one must feel when they wake up to their surgery and found their hair in ponytails, reminiscent of when they were a child. The surgeon visited this young woman and let her know that he braids his daughter's hair all the time, and that he was able to hide the incision and stitches in between the parts of her braids. I'm not gonna lie, I could have tears right now because that's just amazing. I want to thank you all for joining us. I hope that you all come with an open mind and an open heart, and make sure to support Dr. Canty in any way, buy her book. And with that being said, I'm going to leave you guys with a quote. Martin Luther King said it best: of all the forms of inequity, injustice in healthcare is the most shocking and inhumane. Thank you.
Thank you so much. Letting your brother-in-law in. Thank you, thank you, thank you for setting the tone, setting the stage for the conversation that we are about to have. I appreciate you so much. Okay, so
Appreciate you having me.
I have to find her. There she is. Okay, so I now have the pleasure of introducing Stephanie Clark, who is going to continue our conversation and introduce you to our guest speaker, our next guest speaker.
Good evening, everyone. Josh, thank you again for setting the tone. That was spectacular. And I'm just going to take a couple minutes to present to some, introduce to others, Dr. Lucinda Canty, excuse me. She is a certified nurse midwife, researcher, passionate advocate for social justice, and assistant professor of nursing, currently providing reproductive health care. Her research interests are maternal mortality, severe maternal morbidity, health disparities, and maternal health outcomes, creating safe spaces for Black women in healthcare, and addressing racism in nursing and healthcare. Ladies and gentlemen, brothers and sisters, Dr. Lucinda Canty.
Thank you, and thank you for that introduction. And Joshua, that was beautiful, beautiful, a beautiful piece of work. So I'm going to just kind of talk about like what started me on my path to addressing maternal health. And I just would like to then leave it open for questions and discussions. So, I started, when I became a nurse, I was very young, I was 21 years old. And I learned how to take care of other people before I really learned who I was as a person, as a woman. I learned how to care for people who were critically ill and dependent on the care that I would provide. I was also very naive when I entered nursing. I did not believe that nurses could be racist. I just did not believe that that could happen. I was like, you could be however you were at home, but when you came into the hospital, you didn't behave that way. You provided everyone with high quality care. But that was not the reality that I saw. And I was very shocked by that. To see patients treated differently, offered different treatments. And Josh, you were talking about hair. I'll never forget this woman who was 76 years old. Her hair was so matted. This is my first time encountering this patient. her hair was so matted that we had to cut it off. And the patient had like dementia. She was very confused, but it's still a sense of pride and very important to our culture. And at the same time, we were sending white patients to get their hair done in the salon. I'm dating myself at Hartford Hospital, but they used to send women to get like a press and curl and come back up. And then I had this woman in front of me who no one even put a comb through it. And we tried to save her hair and we couldn't. So we had to just cut it all off and let it start and really made sure that she got the hair care that she needed. But that's something that's so important to us, even though some people are saying, oh, it's just hair, but it really goes to how we care for each other, especially when we're entering the healthcare system. Because I could treat your disease, but I also have to treat you as a person and a human. It's like they go both together, even though people try to separate them. And, nursing, that was the start of my career. And as I continued to go through, I started to see things, but I didn't really understand. And especially when you're right in the midst of it, you don't really know. And I decided that I want to go back to school to become a nurse midwife, and was in a program where I went to Yale University. I had an excellent education. The one thing that I felt was missing was seeing myself represented in learning about the history of midwifery, or what about issues that were important to people of color. It was like those things were missing that I had to find spaces, and that's where I learned how important history was. I didn't know about famous nurses until I did my own work. I learned about Tuskegee School of Nurse Midwifery, which was in the 40s and was for Black nurses to become nurse midwives. And I looked at the work that they did and how they cared for women who didn't have anything in the home, no electricity, no running water, but they were still able to provide safe care to the women they served. The school even decreased the maternal mortality rate to 0 in their community and significantly decreased the infant mortality rates. So I was like, how was it during that time that they had less resources, but we're still dealing with those issues today? And that was a mystery for me. And when I entered my PhD program, I knew that I want to look at health disparities. And I started looking at maternal mortality, but I was looking in other countries because I want to know, how are women cared for when there was conflict? When there was some type of war going on, or they didn't have midwives in their communities. And what I learned was that in some of those countries, they had better health outcomes than Black women did here. That was shocking for me to see. I didn't even realize, my son is 12 now. I didn't even realize that when I had my son, that I could have died. And I had risk factors. I had a cesarean. I had all those things that contribute and that placed me at risk. And I didn't even know, as a nurse midwife, I didn't even know. It was when I started to do my own research that I was trying to understand what the issues were. And when I first went to the literature to look at what research was being done, nobody was even looking at Black women and their childbirth experiences. I looked at 2,000 studies. I only found one study that actually looked at their woman's experience, and they looked at women who had cesarean births, but nothing about what it was like just to give birth in this country. And that was a piece that was missing for me. And when I would go to people who were healthcare professionals, who are researchers, and I would say, why are Black women dying? I heard, oh, they're poor. They don't get prenatal care. They have a lot of diseases. They're obese. Those were the things that I was hearing. The way that they described the women who are dying or coming close to dying, I was like, I work with a lot of Black women. I worked in a lot of communities. I don't know that woman. I've seen women who were living below the poverty line, and they came in the first trimester for care. And so I said for myself, I wanted to talk to Black women who had severe complications to see what is it about their experience that could place them at risk. And what I found, and just meeting the women, they were educated from high school all the way up to PhD. They all started prenatal care in less than 10 weeks. One woman, I think she started prenatal care at conception. She said they couldn't even see the baby on ultrasound yet. So that's how quickly she went in for care, when she even suspected pregnancy. And all these women attended every prenatal appointment. They had insurance, they had access to care, but they still found themselves at risk for almost dying. And so that was the mystery to me. I'm like, they're doing all the things that people said placed them at risk. And I was able to hear these stories. I always wonder about the stories of the women who didn't make it. And I'll share with you some of the situations that I found in my study, just to give you an example of what women experience sometimes in our healthcare system. There was a woman who was healthy when she entered her pregnancy, again, started prenatal care early, had her baby. She did have a hemorrhage, but she said it wasn't even explained to her how severe that was. So, so she was fine, the baby was fine. She was discharged from the hospital about 11 months later. But since she had the baby, she was always feeling like tired. And she just assumed that it was just a part of being pregnant and giving childbirth and she had a cesarean as well. So she's associated with that. But one night she woke up with chest pains. And when she got up and walked around, the pains went away. She said, if it happens again, then I'm going to go to the hospital. The next night it happened again, and she went to the hospital. She said she was evaluated in the emergency department, and the doctor said, oh, you just have a little angina. Just go home and rest, and it will go away. And most of us know chest, whether you're a medical person or not, there's no such thing as a little something when you're having chest pain. But still, she was made to feel almost like she exaggerated her symptoms. And so she was about to leave, and another doctor stopped her. She doesn't know where this doctor came from. She thinks that her nurse may have got this doctor because of the way that she was being treated. The doctor said, I can't let you go home. And she was dressed. She had her discharge papers in her hand. He was like, we cannot let you go home. We have to do more tests on you. So when they did the further testing, it turned out that she was in heart failure. Her heart was functioning at a 10% ejection fraction when the normal is 60. The doctors told her that if your heart doesn't improve in 3 months, you're going to need a heart transplant. So that's how severe she was. And she says, if that doctor didn't come in, I wouldn't be talking to you right now. And all that provider had to do was really evaluate her and take her symptoms seriously. And she just imagined, she said, I can't. She's like, all I could think about was I had a daughter and my husband. So what was like, how were they going to even survive without me? And the other thing she said was, if I needed a heart transplant, who was going to give this Black woman a heart? And I forgot to mention, she was 28 years old. So again, started prenatal care on time, was healthy in the beginning and throughout her pregnancy, but still found herself at risk. And we're still doing further investigation to understand why, but we know a big part of it is the stress that we do experience, but also how we exist in our healthcare system and how it's so important to listen to women and trust their bodies. And that was one of the big pieces that I found in my study, was that women who had providers that listened to them, they had a better experience than those who had those complications, and the providers made them feel like they're exaggerating, they're wasting their time. There was one woman who she was having a headache, and she took her own blood pressure. It was through the roof. It was like 170 over 110, when the normal is 120 over 80. Called her provider and said, this is my blood pressure. And he was like, oh, okay. She's like, well, should I come in? Oh, yeah, you could come in. So because he was so calm about her symptoms, she got in her car and drove to the hospital. When she got there and they started checking her blood pressure, she said everybody was running around she had to be admitted to the ICU. But she had preeclampsia, which involves a lot of body systems, but blood pressure is one of the signs, but it could also lead to seizure and stroke. And she could have had those on her way driving to the hospital. So it's these stories that I'm able to hear, but I always wonder, what about that person who their doctor was like, oh, well, if you want to. And so they didn't go, or they were driving there and then she had something happen while she was driving. So just through my research, I found that there were women had different levels of education or information about their complications. Some heard of preeclampsia and thought it was just swelling of the ankles. They didn't realize it was a life-threatening condition. Some never heard about their condition until they were being diagnosed. And even though they were having signs and symptoms, they didn't even know that they were related to a complication because they were made to feel like it's just part of being pregnant. So information was a big piece. The other thing was the relationship with the healthcare provider. Either a healthcare provider was a source of support or they were a source of stress. And women encountered them from going to the front desk and checking in. It was like, that's when everything started, where people wouldn't even look up to look and say, oh, how are you? You have an appointment today? That it was more like, where's your insurance? You know, give me your insurance card so I could make a copy. So it was started there, and then they felt certain people on the healthcare team made them feel like, again, like, you know, you're bothering me, you're trouble, or, you know, you can't speak for yourself, or you don't know and understand your body. And I say, like, in this country, we really have to look and understand this, because you could be, you know, you could start prenatal care early. You could be, you know, educated. You could have insurance. You could be Serena Williams, and you could still die in the United States with all the resources we have. So people have to understand that this goes more than those socioeconomic things that people talk about, or everyone likes to talk about social determinants of health. But what are the root causes of that? And why is it that I have those things that are supposed to keep me healthy, that I'm still at risk? And why is it that I'm entering the healthcare system and I'm going to every appointment, and there were signs that were happening throughout, but I was made to feel like they were normal? Or I'm telling someone I have pain and people treat me like I can't trust my body. So for me, with my research, I'm really looking at using the voices of Black women, letting us decide what it is that we need in our healthcare system, and also let us tell you what we need and what needs to change. Some things we can look at on our own, and some things are structural things that are happening, but I still feel like now those things have to be challenged. We can no longer keep doing the same things that were done when Florence Nightingale was practicing. We have to change and make sure that our needs are being addressed. Every other race, ethnicity is improving. You know, the only other community are Indigenous Native Americans, who are very closely behind as far as maternal mortality. And it's just so, for me, it's just like when you look at our history in this country, you understand some of the challenges that we're facing today. I look at Black women and I say, when did we ever have control over our bodies? You know, we were always seen as property. We were always seen as less than, even though we contribute so much to nursing, to medicine, to healthcare, and all the roles that we play. Why is it that we can't have our healthcare needs met? So that's the question that I have. And I'm working now to establish an initiative called Lucinda's House, where I create a safe space for Black women to talk about the issues. And again, we'll sit around what I'm calling the kitchen table and develop solutions. And we're gonna work as a collective, because I feel like I feel like our society is always looking at the bad things that are happening. They don't look at all the good work that we're doing. They don't look again at our contributions that we're making. They don't even look at us to see that we want to take care of ourselves. We're taking care of ourselves. They're not looking at when we enter the healthcare system, we're hoping that that system is going to support us and keep us safe. And a lot of times that's all we want, is to be seen and heard. And then all these other things will fall in place for us. But it has to start with people seeing us as being human, and that we know and understand our body, that if I say I'm in pain, that I'm in pain. If I want more information about something, give me that information. Those are the things that we want, but it just all boils down to being treated as being human, and starting there, and not seeing us as just property, as just somebody who's just taking up space. We're here for a reason, and those are things that we have a right to. We have a right to safe, competent care, regardless of where we go. If we're giving birth in the home, or if we're giving birth in the hospital, we have the right to feel safe and protected, and to feel like whoever's providing our care really are invested in our health and our well-being. Okay, thank you. So I'd like to open it up to questions and discussions, so we could further talk about the issues. And I can also share, if you have questions about my work, I'm also willing to share that.
Hi, can I ask a question?
Yes, yes.
How is it in your profession? How is it for you when you encounter coworkers that may not be culturally sensitive or even aware of some of the statistics that we talked about today? I just wanted to know, how do you approach that? And I can just say recently in grad school for occupational therapy, it was rough because I'm I'm here to do this, not be the educator for everyone here and even the teachers. So how do you handle that without getting kind of pulled into extra stuff?
Yes.
That's about it. Thank you.
Yeah, thank you for that question. And that was something when I was that young nurse, a lot of times, even that early when I first became a nurse midwife, I was very silent because I felt that if I gave that time and energy, it would take away from the care that I was trying to provide. But as I start to get more experience, I was like, you don't know more than me. You're not better than me. And half the time, you're not even providing half the care that I provide to the patients that I'm caring for. That I don't care what you do or how you put me down, you're not going to be able to provide the care, especially from people from my community. So, there was a time when, like, for example, I was delivering a baby and the nurse was ridiculous. But I have this woman about to give birth that even the patient's like, what's wrong with her? And I'm like, don't focus on her. Let's get this baby delivered. You're what's important. And what I realize is that a lot of that, I kind of internalized though, a lot of that behavior, I was like, I can't deal with that right now. But what I found was I was still being impacted by that. Like deep down, it was causing hurt, but it was like, I didn't want to address it. But then I learned that in the past year, I forgot to mention this, of September 2020, I started discussions about racism in nursing with two other nurses who we just got together and said, as nurses, we're in the middle of all this. You know, this was after George Floyd. You know, even for myself, that was a year that I finished my PhD, and I had to fight to get my PhD just simply because I was Black. I'm just gonna say it. And then in my study, learning about the women's experiences and how there's always extra that we have to go through just to get the basics that we need. So it was like all those things were building up that I was like, I'm not going to be silent anymore. So, but what I do is like when there are things that happen, no longer am I like, let's just put it aside and wait. I address it head on. And I said, this is racist. What you're saying about that patient, that's racist. How you're treating me is racist. You know, what you're doing, that's structural racism. I had to break down structural racism to one of my colleagues. But what I do is I call it what it is, but now it's your turn to do the work. You know, in the past, I used to worry about, oh, I'm going to hurt their feelings. They're going to feel a certain way. But I'm like, but their behavior, they don't care how I feel. They say whatever they want and they don't care how I feel. So I was like, you know what? I'm going to say whatever I want to. And one of the things that I've learned over this past year is to call it what it is. Because you try to be sweet and say, you know, they're like, well, this patient said I was racist. Was I racist? And I used to be like, well, you know, but now I'm like, yeah, that could be considered racist. Because when I'm sweet and I talk to them and make it beautiful, they continue with the behavior. And my thing now is that I have to disrupt that behavior. You know, I don't care if for 400 years, that's what you've learned and that's what you've been doing, is gonna stop because people's lives are at risk. I'm like, racism kills. It's not about me having my feelings hurt because you said the wrong thing. Racism places my life at risk. It places Black women's lives at risk. So no longer am I gonna accept the cute way of saying things. I'm like, look, this is wrong. And I don't care how you learned about this, it's gonna have to change. And what I've noticed by doing that is that people are more receptive and more open to listening because it's not making things pretty that they leave thinking everything's all right. And I'll say this really quickly because I see a hand raised. Like I had a colleague who was trying to create policies because that's another way they get us. They do policies and procedures that help promote what they're doing. And that's where a lot of this has to stop. And I told her, I said, you're creating a policy that's excluding people who look like me. And I broke it down and I told her about herself. She left my office. I was like, I won't see her again. 10 minutes later, she came back in and she's like, I listened to what you said and you're right. And I said, I know I'm right. I said, this is my experience. This is my life. And even though I had to have that tough conversation, it made our relationship stronger and it made what she does for her patients better. So sometimes you just have to address it, but you still make them do the work because that's too much of a mental energy for us to worry about them. But I'll you go do the work. The next time I see you, I don't want to see that behavior. Mm-hmm.
Thank you. I like that last part right there. I'm gonna have to write that.
Yes.
Thank you.
They say they didn't know. The first time you can say, oh, I didn't know. I didn't know that's how I sounded. I didn't know. But the second time, you can't say that anymore.
You better have Googled something, okay?
Exactly.
Thank you again.
Thank you. Okay, Mr. Harris.
Yeah, good evening, and thank you so much, Dr. Canty. This is fascinating. I did not want to miss it. I've had a full day, but there's no way I was missing Dr. Lucinda Canty. So thank you. First of all, do you know my colleague Heather Reynolds at Yale?
Yes. Oh my God.
Good people.
Yes.
But thank you for what you said. And I want to start with a quote by Dr. Ken Hardy, a colleague. I love him. He's at Drexel now in New York. But he said this, and it's related to the last person, I think it was Jessica's comment. He says, when he's talking to a bunch of medical students, and they asked him the question, Dr. Hardy's African-American, why do you all always bring up race all the time? And he said he paused, and he says, because you won't. He said, but I'll commit to bringing it up less if you commit to bringing it up more. And so we have to, because they won't. And I love that quote, and I kind of live by it. And I'm always ready to answer because, as you said, it is the case. And so I'm bringing it up because this is it. And so with that, I thank you tonight, especially for making the connection between the historical accounts, because I think, and I'm in women's health and midwifery for 3 decades. And so midwifery is like my thing. I love midwives because I knew the history, and I knew in the 50s, the great movie, All My Babies with Mary Corley and so forth. And I grew up with that and knowing the history of midwives. And it wasn't for our Black midwives during slavery, then our babies more would have died. But I also remember as the doctors, white physicians started coming into play in Western medicine, they demonized the midwives. And like in the turn of the 20th century, we had about 400 midwives out there. But after what they did to Black women, then they were like, a handful left in the country. And so we think about that gap in midwifery. So that to me is important to understand the history, as you said. And then we think today, the 3 levels of midwives, for example, certified nurse midwives, certified midwife, and the certified professional midwives. And the fact that the certified professional midwives can only practice in 35 jurisdictions in this country. And when we have such a great obstetrical need, it just bothers me, irritates me, the advocacy we have to do even for those certified professional midwives that can't practice in some states. And Connecticut happens to be one of the states that CPNs cannot practice in. So we should be outraged because it's been midwives and doulas that have carried our communities, both African-American, Native Americans, that we're here because of the midwives. And so I just pray, and I hope that this committee can do this, Kia and Stephanie. This is something to bring up because they literally, we're here because of the midwives birthed us here. Exactly. And the fact that they were wiped out, demonized by doctors, white doctors themselves to make room for their experiments on Black bodies, to your point as you open this up, Josh, that history is so important to understand, to contextualize what's happening, and it gives you a different way of speaking in the 21st century. So I applaud your work as a midwife and PhD. You're such an example, and I'm inspired by you. And again, I wouldn't have missed tonight at all. And I'm just really proud to be here. So thank you so much for that. And lastly, do you know Dr. Karen Scott? Anyone on the call, Dr. Karen?
Yes.
So Karen, so Scotty, she left, her whole life, little Black girl, I want to grow up and be an OBGYN, but she realized the assault from white doctors and she left that to do her research, and she's doing phenomenal work and has created a whole scale of measuring racism in obstetrical care. But she's, to hear her story, this is someone, a Black child who grew up, became this doctor, that was my goal, just to realize, wait a minute, these are the people that hurt my people. And she stepped away from that, which is, she's another queen for us. And I just wanted to lift her up too.
Exactly. Yes.
Thank you so much.
Yes, we're actually going to be working together. We're working on something, putting something together. Yes. And I just want to say something about the history, And, again, when you're young and you hear history, you think that what you're reading is the truth. And it was doing my own work, because they would say that midwives, traditional Black midwives, that they were dirty, they were causing harm to women. And when I did my own research, again, they didn't have running water, and they found what the women needed. And the thing that really touched me too, learning this history, is that they didn't want payment. I mean, they wanted to get paid, but if someone didn't have payment, they weren't going to say, oh, I can't see you. Almost like today, oh, we don't take that insurance. They would get payments from just someone, whatever they had, they could give. I was reading about this midwife that got chickens from a woman that she delivered. But it was a sense of community. And there's this lie that's being told that when these white doctors came in, that they were going to improve health outcomes. When you really look at the numbers, they were doing twice as bad as what was happening in these communities that didn't have anything. So, and they had the alleged resources. But I really just learned that as midwives, and I think that people create these barriers to prevent us from getting the education too. So, you do the training, you could become a midwife, a professional, certified midwife, but then no, we need nursing. Also, do you have to do this? And it's like every time everything just keeps going up on what you need. It's like what we do and we do it well is not good enough. So you need to add this on. It's like we always have that extra to do, but we need to go back to what we were doing during that time, because the birth outcomes, people are surprised by this. The birth outcomes in the 1940s, when there was segregation, when hospitals could say, no, you can't come here, they were better for Black women than they are now. The experience was better for Black women than they are now during childbirth. So we have to go back to our roots. And I do believe in midwives. However you enter midwifery, we have something to contribute, especially when we're from the community. And the same with doulas as well. We have so much to contribute, and people have to stop trying to devalue what we have to offer. Because I always say to people, there are things that we can do in our communities that other people can't do. I don't care how many degrees you have. You cannot just suddenly enter a community that you know nothing about and provide better care than the people who are from the community. It just can't happen.
Lucinda, I have a question. So you are a professor, right? Like a nursing educator. So I'm certain that your students are getting a full and complete history, right, of healthcare and nursing and midwifery. How do we, is there a way to make sure that like schools like Three Rivers and like other places that have nursing programs are also giving their nursing students comprehensive education, right? So that their curricula is not Eurocentric.
Yeah.
How does that happen so that our nursing students are better prepared to go out and serve the community?
Yes, and that I have to tell you, every Black History Month, though I don't put it on the syllabus, when those students come into my class, they get a Black history lesson. You're going to learn more than Florence Nightingale. And I go through and I ask them, and these students have and these are senior level students that I'm working with. I asked them, have you received any history about Black nurses or any nurse of color? I get a lot of blank faces. They're like, no. And I'm like, who do you hear of? They're like, Florence Nightingale. And I always say, was Florence Nightingale taking care of Black people? Was she taking care of Native Americans? Latina? I have the students thinking, because I'm like, who was taking care of our communities before anyone else wanted to even touch us? And then that's when I have students looking on their own, trying to find out more about their history. I actually had, the last time I talked about this, I had a Latina student say to me, I want to become a midwife. I want to look at my history, because I never heard anything about this. So the history is so important, because I think all students have to realize we all contributed something to nursing, to healthcare. The problem is who is providing the education. because you have to make sure that people see that this is not abnormal, that you're talking about Mary Mahoney or any other Black nurses, that this is a normal part of history. But it has to start with a predominantly white profession, not to say they still can't talk about Black history, but they need to be educated themselves first. They need to be educated on how to be anti-racist. Because if you're coming in and all you've learned was Florence Nightingale, and you're like, oh, I can teach about cultural competence. You can't teach about cultural competence if all you know is Florence Nightingale. If you can't teach about cultural competence, if you don't know the history of the people that are being served, the community that's being served. You have to know that history to understand why we still have some of these challenges today. I'll even give you an example. When I was teaching about implicit bias, and everyone's like, implicit bias, what's that? So the example I always go to is pain in Black women. And I say, where do you think that started? And nobody knows. I said that actually started with slavery, so that we could have our babies and go back to work, so that we could have our babies and have our babies taken away, because we don't feel and understand our pain. So I said, these are even the experimentations. I'm like, that was done because that was done on us without anesthesia, because people believed that we didn't feel pain. And I said, so let's go now to 2020. You know, women are going home who have a C-section with ibuprofen. Black women, this is an actual study. Black women were sent home in ibuprofen, white women were getting Percocet. This is major surgery, major surgery. I had a C-section, so I can tell you ibuprofen was not helping me. You know, and I knew how to use Percocet. I knew how to use it to take care of my pain. And that's what I wasn't drug seeking. I had major surgery and I needed something to help me with that pain so that I can get up and move around and take care of my son. But anyways, when we're looking at some of the beliefs that are happening today, we could go back in history and you can see it. And whenever I give that, I talk about that in my class, the people are like, oh my God, now I get it. You know, when they think about the patients that they see. I even had one student say that there was a patient, the patient did have a history of substance abuse, but the patient fell down the stairs and broke both legs and wanted something for the pain. And the nurse said, oh, he's drug seeking. 2 open fractures on his legs and he's drug seeking. But anyways, we had a discussion about that. But you have to know that history to be able to talk like that with students. You have to make sure that you're teaching it in a way that's not perpetuating stereotypes. Because our textbooks, the nursing textbooks, they're ridiculous. Look at any nursing textbook and see what they say about culture, especially what they say about Black women and Hispanic women. It's disappointing, but then you see why people don't know better when we enter care. And I'm telling you, this is a textbook from 2019. They have a new edition. A colleague of mine sent a letter in because I took a picture of it. I was like, look at this. She sent it to them. And first thing they said, the publisher said was, oh, that had to be from 10, 20 years ago. She was like, no, it's 2019. And so they said this new edition that's coming out this year is supposed to change that. But if you look at any, I want to challenge you to pick up any textbook. And I want to just say this, and I'll go to some more questions. There was a Black student who had eczema so bad. She didn't know she had eczema. She was like, I do? But she didn't see that in her textbooks and her Patho Farm book. And the woman who teaches Patho Farm looked at that book from the page 1 to the end. There were not one person of color in the book, not one. That she had to go on, when she teaches, she has to go on Google and download some pictures. And this is a textbook that's like, I don't know, like 1,000 pages. And she was in a meeting saying, oh, you know, there's no pictures of people of color, but that's not racism. I didn't call her out in front of everyone because I did like her. I pulled her aside and I said, by us not being in that textbook, that's saying we don't exist. And that is structural racism. You know, and again, that was a learning moment for her because I wasn't going to let her leave thinking that wasn't racism. And they're hoping, she also is saying that she's going to write the publisher. So we'll see what happens. But those are those things that our students are seeing, that they are taking as a truth because it's in a textbook. So we have to do better on a lot of levels with who's teaching our students and, even how that information is being delivered, but also to stop just pushing along these textbooks that don't address the needs of all communities. Because they're making some good money. Until you have 66 students now that are buying these textbooks, that's a lot of money these companies are making. Okay. Oh, yeah. Oh, sorry. I just saw your note about Florence Nightingale. And this is true and documented that Florence Nightingale did not take care of African Americans or Native Americans, that we were less than, that there was even Mary Sicoli, who was considered, just an early nurse. She wanted to work with Florence Nightingale and she was rejected. She ended up still working as a nurse. She had to work during the day because she was not getting any reimbursement working as a nurse in the evenings. And she did that every day. We even consider Mary Sicoli the first nurse practitioner because the way that she looked at diseases and developed treatments for them. And that's not in the history books, but it's our history, it's our nursing history.
Do we have any more questions for Lucinda, or comments or reflections about all that's been shared today?
I have another quick question. When is your book coming out?
Well, I'm working on something now, so hopefully, hopefully soon. But I do want to say the American Journal of Nursing, this month's edition, there's an article about the lead author about our project Overdue Reckoning on addressing racism in nursing. And my artwork is on the cover of the magazine too. It's free this month. It's free for a couple more days.
Is that something that you can send a link to and then we can share it with everyone?
Yes.
Excellent.
Yes.
Please, please post all the shameless plugs.
Okay. Okay, I can put, actually, I can put it in the chat. Do you want me to put, I can still send it, but I could put it in the chat. I did a couple of things. There was a video abstract I did with the authors, and then I did a podcast about my experiences in nursing with the editor too. So those are the links, but I can send them to you also, Stephanie.
Excellent. All right, so I know we're scheduled to go a little bit longer, so I just want to leave a window if anyone has any more questions or comments, and if not, no one's
For Dr. Canty or for Josh, right?
yes, for either of our blessed speakers this evening.
Yeah, Josh, where's your book?
I'm working on it. I do have some zines as well. Oh, and I can share this piece, the written piece, to Kia, so that you guys can share that out as well.
Thank you.
Yeah, Stephanie, just to give Josh some props, I was in a grocery store 2 weeks ago, and this white gentleman was talking about this educator and began to describe you. And I met Josh through my son a little while ago. I was like, does he have dreads? Does he have a big old smile? And he was talking about you. So just, again, your work and your presence in community is awesome. So I just wanted to lift you up for that. So thank you for tonight as well.
I appreciate you. And at the end of the day, that's what we are here to have, these conversations, these difficult and uncomfortable conversations. And if we're making people mad, then we're doing something right. So I will encourage you all that conflict is not a bad thing. That's how we get growth, and that's how we truly start to learn. So definitely commend you all for having this today. And I'm glad that you're recording this as well, because I definitely want to help post this out to some of my friends in the medical field. And I do want to say one of my friends is actually getting her doctorates. I forgot what school she's at right now, but she jumped on and she was enjoying the conversation as well. So, definitely appreciate you having this, and definitely thank you, Dr. Canty, for coming and joining us.
Thank you.
There is a question in the chat about why you all, and I'll pose it to both of you, why you decided to do what you do.
Josh, do you want me to go?
I mean, go ahead.
Okay, so for my family, like I was like, I want to say I was like in 10th grade when I finally decided what I want to do. I actually want to be a chef, but I always had that desire to care for people. And in my family, like we would go down to Atlanta to visit my mother's family. But there was a lot of diabetes in her family, a lot of hypertension. And then just helping them get their meds, giving shots. I was like, that's what I want to do. So that kind of started my path in learning more about nursing. And as far as midwifery, I actually was wanted to work in the newborn ICU. And I saw a woman give birth in the hallway in one of my clinical rotations. And she was like screaming. And then there was a midwife who actually delivered her baby in the hallway, and how the woman was just like at peace when the baby was born. And then it was like everybody was happy to see the baby. But I loved how the midwife cared for her. And I was like, that's what I want to do. I want to do that. So that started my kind of my journey to become a nurse midwife.
Yeah, I've always been, doing music, poetry, doing something, making noise. Coming into this position though, definitely I've been trying to focus, coming back to the community, ways that we can help out the community. Being able to, we were able to do a marketplace where we were giving out meals and giving out, vegetables. I think that's what, really will bring the community together so we can network, so we can be helping each other out. And I think that's what keeps me motivated. It's crazy you say that story because you made me think about, I had a friend that teaches in DC, and we have teenage girls that are out here pregnant, so scared to even come forward and talk about it, to the point where my friend said that one of the students gave birth in the bathroom and nobody knew she was pregnant, to the point where they called the father and he's like, where's such and such, and I'm like, oh, her and the baby are fine. And he said the baby. And just imagine being so terrified. You're a teenage girl, middle school, high school, you're so terrified of your father. I think that it's really important for more Black men to be in these conversations as well. My close friends, his wife just had twins, and it was a specific type of twin that was a complication. And he was doing the research. And if we learn more about these things before becoming a husband and before becoming a father, we could be in a much better place. Where we can be more informed. And again, make sure that our Black women are being listened to and protected.
All right, so Kia is recording this. It will be up on a YouTube channel. It is streaming on Facebook Live. So anyone who shared it, that you can share it and people will be able to see the playback. We will send a link once it's posted to YouTube, send some resources, share some links from Lucinda, share the gifting that Josh gave us at the beginning to set the tone. And Kia, do you want to share with us about our next, there it is. You're on mute. You're muted.
I couldn't find the mute button with this thing shared. So we do have a date for our next session. Not much more information than that, but save the date, especially if all of your Thursdays feel like this Thursday. Please add us to your calendar and join us back here when we continue this conversation about equity. And maybe I'll put racism is a killer. That's my takeaway. Racism is a killer. We might put that on our flyers from now on. But thank you to both our speakers. Thank you to the HIC for entrusting me with this evening, owning the Zoom, being in charge of the Zoom and the slides. And thank you to you all. See, I'm sure you all have this, the 24th. That's up. Thank you to you all for joining us this evening. I know that some people might be Zoomed out or Facebook Lived out or meetinged out, but these are always refreshing, and it is great to be in community with you all. So I appreciate you all, and I think that the HIC members and the HIC coordinating team do as well. And thank you again to our speakers and to everyone, and I hope you are well, and we will see you again soon.
Yeah, thank you. Kai, you were excellent. Excellent.
Yeah.
Weird, it's okay. I just be weird. I just,
Why be normal? Why be
you know
normal?
what I mean?
Yeah, I love it. I love it.
All right, guys, have a great night. Thank you.
Y'all take care.
Thank you so much, everybody.